So I tried to throw together some cases that might be a little bit different than what we've talked about. Just these are all real patients that I have seen personally within the last year or two. I tried to do just some high yield, I guess more fun, thoughtful cases just to highlight a couple different points about acute stroke management that may be different than what we experienced even 5-10 years ago. And so I'm just going to go right into it. So this part will be fun, hopefully. So 66-year-old woman, past history of multiple vascular risk factors, which is common, was admitted after being found down. And you can see I named all of these appropriately, so this is going to be a straightforward carotid athero, so if you want to take a quick nap, you can. Just kidding. Hopefully it'll change a little bit. So unable to have, left MCA syndrome, high stroke scale, unable to have CTA due to an iodine allergy, when we all say, oh no, and then what are we going to do? And we try to get a hyperacute MRI. So what we actually did, because the stroke scale was so high and her last known well was 10, maybe if this was a patient who came in within 6, 7, 8 hours, maybe we would have just been more aggressive and taken this patient straight to angio suite. But given last known well of 10, we ultimately decided to do what we call hyperacute MRI, which is basically where we just do a flare, DWI, ADC, and an SWI. So those are our 4 sequences, and we get them out. And we did an MRA, showed a left M1 occlusion, which is what we were thinking, but more importantly, did show that she still had a very large left hemispheric mismatch. So this is ultimately what we found. This was her DWI. I didn't have her perfusion imaging, but it was pretty much the entire left hemisphere from an MCA territory. You can see on this angio, this is the pre-thrombectomy versus post. Pre-thrombectomy, you can see that there is a left M1 occlusion, which was nicely recanalized, probably at least a TICI-2C or TICI-3. And then what we noticed is there is this very clear, about 60% carotid stenosis. So fairly straightforward, right? This patient came in, left MCA syndrome, has 60% or so carotid stenosis, so we're thinking that this is probably a symptomatic carotid at 60%. Let's get her arranged for a CEA and go from there. So underwent, there we go, it's TICI-2B, cerebral angio 60%. All of this we talked about. We did the rest of her workup while we were waiting to get her to neurosurgery for a CEA. TE, so transthoracic, showed some posterior mitral annular calcification, and then a TE did not show any thrombus or vegetation. So we were fairly confident in our plan moving forward, planned, and then just prior to CEA, of course, I wouldn't be presenting this case if it didn't have some twist. We saw this. So without getting into this too much, basically this is a 100 and a 400 mag view that ultimately showed a lot of calcified PMNs. And this was actually located from our pathologists. They called us and said, wait a minute, there's part of mitral valve here. And we said, excuse me, what was that? Yeah, there was a piece of calcified mitral valve that had been identified from the thrombectomy. We tend to send all of our thrombectomy specimens to pathology, and we were called saying that there is a calcified mitral valve that was retrieved from the specimen. So, consulted cardiology, and ultimately the patient was discharged on dual antiplatelet therapy with a plan to repeat a TEE 6 to 8 weeks and cardiac telemetry as an outpatient. But again, just a quick, not all things are as straightforward as they appear. Mitral annular calcification, chronic non-inflammatory degenerative process with calcium deposition on the annulus of the mitral valve. So sometimes what you'll see is you'll actually see a calcium embolus that you can identify pretty clearly even on a non-con. You'll see that there's a piece of calcium right in the vessel, and that's a little bit more striking. So I was surprised that we didn't see any calcium here. And sometimes, though, it's hard to say, is that calcium that has embolized from somewhere, or is that calcium from intracranial athero that has developed over time? So pathology in this case was really, really, really helpful. And I don't know if many of you at your institutions are sending, some of these thrombectomy specimens for pathology, but it's been fairly helpful to us on multiple occasions. So no clear treatment guidelines for cardioembolism from MAC. It's relatively uncommon. And to our knowledge, this is the first time that this has been reported that we have actually identified part of a calcified mitral valve from a thrombectomy specimen intracranially. So case 1A, a quick detour. 80-year-old guy, history of prostate cancer and COVID just prior to his admission, who was admitted for witnessed right MCA syndrome at home. So the opposite of what we just saw from the last lady. Initial exam, full right MCA syndrome, high stroke scale, CTA, right ICA occlusion, received IV thrombolysis, underwent thrombectomy, TICI-2B. And after his initial exam improvement, again, remember, right MCA, patient acutely declined with a new left MCA syndrome. Imaging revealed a left ICH. Pathology from the thrombectomy grew enterococcus, as did blood cultures after we got the results back from pathology about the enterococcus from the thrombectomy specimen. So TEE ultimately showed aortic valve vegetations projecting into his left ventricular outflow tract, likely that this was cardioemboli from infective endocarditis found on thrombus, found in the thrombus, and possibly left hemispheric mycotic aneurysm that led to his ICH. So again, another instance where the specimen from the thrombectomy really changed our complete management. And it allowed us to be able to explain why he was having things on both sides of the brain, because initially we were a little bit confused about why all that had happened. So again, interesting cases that highlight hopefully some importance of knowing what is embolizing. And again, these are zebras, but we often see zebras. So just a quick, let's make sure that everybody's up to date and do some teaching through these cases. According to the AHA, ASA guidelines, what is the ideal time frame for revascularization of a symptomatic extracranial carotid stenosis after a minor non-disabling stroke? And this is good. We have a little bit more variability here, but everybody's still on the right track. I know. People change. They're like, oh, wait a minute. Wait a minute. What's B doing up there? Yeah. I see Glenn over there like, oh, I better change my answer. Really, it's B was correct, so between 2 to 7 days. And there are a couple papers that have looked at this specifically. Reasonable to perform carotid revascularization within 2 to 4 days post-stroke if it's a minor non-disabling modified rankin of 0-2 and carotid stenosis is the etiology. So again, recurrent stroke risk is highest within the first few days. Certainly if someone has almost no stroke burden and you can safely do this within 2 days, fine. Having the brain recover a little bit seems to be favorable. A meta-analysis is where most of this comes from. So favorable rates of complications at least 48 hours out from stroke. And a lot of times we used to be told, well, it's 2 days to 2 weeks. That's what's always been taught. There is some literature that shows that you can still do it up to 2 weeks, but that the outcomes are not much different, or the risks are not much different at 7 to 15 days versus 0 to 7 days. So again, from a risk-benefit standpoint, it seems like the sweet spot is 2 to 7. Still doing it after 7 is reasonable, but based off of guideline recommendations, 2 to 7 seems to be the best. All right, complicated hospital course. This gentleman, 73, a lot of vascular risk factors. You can see here, this is a typical patient. Remote strokes, residual left leg weakness, who was initially admitted for fall at home and right hip fracture requiring surgery. So post-op, had PEA arrest with 4 rounds of CPR until we had return of circulation. We were consulted this is supposed to say post-PEA. Sorry, my brain always goes to CEA instead of PEA. Post-PEA arrest for generalized weakness. So a very classic consult that we get. So thoughts, this is what happened. So initially we said, well, the right side, he's had a hip fracture. Left side, he's got some chronic residual weakness from his old strokes. So it's limited by pain. We couldn't get much out of the right leg. He has a hip fracture. He also, due to his multiple vascular risk factors, had a right below the knee amputation. So not much we can do there, right? So left side, we said, well, it's weak at baseline. Could this be recrudescence? He just underwent PEA arrest, prolonged hospitalization. Maybe that this is nothing more than just some generalized weakness post-arrest and everything else that's going on in some recrudescence. So it turns out, yes, some of us as stroke neurologists do sensory exams, and I do carry a reflex hammer also, just to let everybody know. But what we found is he actually had no sensation from about the waist down. And this is to pinprick and temperature, something that I To be honest with you, I'm not sure. I think it's because we couldn't get a great exam on him, and so we went a little bit further and did more of a further exam. And what we see here is that he had quite a large cord infarct. You can see some vertebral body just above the level that have also been affected. And unfortunately, he had a fairly poor outcome, spinal cord ischemia. But I thought that this is something that is worthwhile to at least highlight and go over. This is something that we see not infrequently. Usually idiopathic, a lot of aortic pathologies. We see this with a lot of aortic surgeries. Vertebral artery dissection obviously can give you spinal cord ischemia, trauma, coagulopathies. Spinal AVF is something to keep in mind. And then fibrocartilaginous embolism is something that we see from time to time again, and then cocaine. So a lot of these are things to keep in mind, but the vast majority of these are either aortic, athero, or post-op patients. Anterior spinal artery syndrome is much more common than posterior, and I know that I don't need to go into all of that for the group here and for the sake of time. So imaging, MRI is gold standard. It's sometimes hard to get MRIs on these patients who are extremely, extremely sick, but this is really what we need. And what we're looking for is an abnormal T2 hyperintensity, often with edema, and then this owl's eyes appearance. So the T2 owl's eyes showing interior horn cells. DWI we use more and more. It is very, very challenging due to the way that the CSF flows through the cord to get a good DWI. So I wouldn't rely on DWI. Certainly it can be helpful if you see it, and it should be attempted, but you can't really hang your hat on it. It's really a clinical diagnosis. Adjacent vertebral bodies can also show infarct. This is what we're talking about whenever we talk about the anterior horn cell owl's eyes. Poor prognosis for these patients. Intact sensation often yields better prognosis. There's no role for steroids in these patients, and lumbar SA drains and avoidance of hypotension, especially if someone's undergoing a surgery that you can plan for. Oftentimes they will put subarachnoid drain or lumbar drains in ahead of time to help prevent some of this hypoperfusion. But otherwise, if you see this patient, and even if it's just post-acute or they're coming out of surgery, the question is always, should we put a drain in now? And that's a very, again, could be a talk in of itself. The literature out there is extremely, extremely variable about this. So avoiding hypotension plus or minus considering a lumbar drain, depending on how soon you think that this happened, may be beneficial. But again, you're not going to find a lot of good evidence-based medicine for that. So tricky cases whenever you have spinal cord ischemia. So case number 3, true or false? A 59-year-old woman, past history, again, multiple vascular risk factors, recent hospitalization for the flu, who was readmitted after being found unresponsive at home. The last known well was the night prior. Initial exam, a dilated fixed pupil on the right, left was sluggish, no eye opening or verbal output, and then she was extending in her bilateral upper extremities to noxious stimulation. She was intubated on arrival, and so that was the exam that we got. I think that everybody can appropriately tell that there is something wrong with the right side of the brain, and this is a very acute subdural hematoma with quite a significant midline shift. So appropriately, she was taken to the OR for evacuation. After the OR was weaned, or after the OR, she came back from the OR and sedation was weaned, she was noted to have, again, about 3 out of 5 strength on her left side, which makes a lot of sense. But then also, we were actually consulted because they said she's having decreased strength on the right side. So no movement in the right leg, 2 out of 5 in the right arm, and was only able to follow simple commands. So not what we would expect someone coming back. And so the question was, what's going on? So is she having an infarct now with everything going on? Left hemispheric, has she bled left hemispherically? Is there pneumocephalus? Is there something going on from a procedural standpoint? Did she have a seizure that generalized and now she's weak also on the left? I see some people shaking their heads, no, that's good. So what could have happened? Does anybody want to? Yeah, well, that's one consideration. Someone said it. Yeah, so what happened basically is that we had, and you can see here very clearly, so this is her scan right when she first came back, and then this is her scan about 4 to 5 days later. So what we see here is that we see uncal herniation. And so I don't want to give it away because we're going to talk about this. So which type of herniation is classically associated with a Kernahan-Woltman notch phenomenon or a false localizing sign? That's why I named it true or false. Results are coming in, and the popular answer seems to be D, with some others lagging behind. Yeah, and classically, this is a transtentorial uncal herniation. So exactly right. So false localizing sign is what this is also referred to. So compression of the cerebral peduncle of the midbrain impinging on the contralateral edge of the tent and creates an indentation or Kernahan's notch. Leads to compression of the contralateral corticospinal tracts, which then leads to motor deficits ipsilateral to the herniating side. And just a brief illustration of how this happens. So something to keep in mind, especially with some of our patients that have increased intracranial pressure or ICHs or subdurals. This is not extremely uncommon. So if you get called and something's not making sense and you do a good exam and you find that there's ipsilateral weakness that was not there before, you have to be concerned about impending uncal herniation. This patient actually did really, really well, and you could see even post-op her midline shift was much, much better, and she had a good recovery, all things considering. Finally, we get by with a little help from our friends. I think I just wanted to use this to highlight some multidisciplinary approaches to what we can do for stroke care that we weren't able to do even several years ago. So we had a woman, 71, who had an ascending aortic root aneurysm, bovine arch, trileaflet, aortic valve, COPD, chronic hypertension, so pretty healthy, who came in and underwent a conventional sternotomy. So you can see here what happened. She had an aortic replacement. She had an hemiarch repair. She had reimplantation of the right innominate and the left carotid. So this was not a simple procedure. Left atrial appendage clipping, that was the probably most minimal part of her OR. And then the procedure was uncomplicated, admitted to the CVICU as we weaned sedation. This is a common thing. About 4 hours after the procedure ended, this was her neuro exam. She would follow commands only intermittently. She had a forced left gaze. She had a right homonymous hemianopia, flaccid right-sided weakness, no response to noxious stim on the right. Stroke scale was 18, last known well 10 hours ago. So what do you do in this situation? CT brain was unremarkable. Her aspects was 10. So she is very clearly having a left MCA syndrome post very complicated cardiovascular thoracic surgery. So what happened, you can see here, we got a CTA, and you can see on the CTA that she had a very proximal dissection flap with very, very minimal flow, and you can see how nasty this is as it extends up the common carotid into the internal carotid. And again, this is someone who just had a lot of changes to her anatomy. Not always a great idea to go in with more catheters through all the grafts and everything that they just did to try to mess around. And you can see here very clearly that there is no intracranial occlusion, but you can see that the flow is much more sluggish than what we see on the right side. So very, very slow flow through that side. So probably all carotid. And so what happened? We called cardiothoracic surgery, we called vascular surgery, we called neurosurgery, and neurology. So all of us had a very quick multidisciplinary conversation about this, and this is what happened. So the patient underwent a reduced sternotomy. So CTS actually came in, they opened up the chest again, and then vascular surgery actually allowed us to have direct access through the common carotid. So right here, direct access. We did a diagnostic cerebral angio right then and there with an open chest, showing this proximal dissection flap at the origin with thrombus. And what happened, we basically put a few telescoping stents from her left ICA all the way down with distal protection, stented the dissection flap, and then post-procedure stent patency on follow-up ultrasounds and partially recanalized ECA also and improved cranial flow. This was her MRI. So pretty remarkable if you think about it. This is what she suffered from, this is post-op day number 4. Discharged to acute rehab. She went back to work 3 months later. Minimal residual right-sided weakness at that time, occasional word-finding difficulties, 6-month follow-up. She said she was nearly back to baseline, functioning cognitively. All of her stents were patent. So the point of this isn't to say, oh, look what we did. It's look what we can do now for stroke patients. This is a patient probably 5-10 years ago that none of this would have happened. This patient, I can't be certain, but probably the outcome would not have been like this. And so I think using all of your resources, using your colleagues, really approaching these cases from a multidisciplinary approach is always the best idea. Getting early scans done and keeping an open mind as to what you can do to really help a patient is extremely, extremely important, especially working with so many great colleagues. So I think that was it.
Thank you.